Good afternoon, everybody, and welcome to this webinar from the RCGP Primary Care Development Program. I will hand over to Dr. Pauline Foreman and Ellie Fowler, who will be presenting the webinar this afternoon. Pauline, over to you.
Thanks very much, Naren. Hello, everyone, and welcome to this webinar on patient access, getting the balance right for patients, practices, and primary care networks. So I'd like to introduce myself and Ellie to you. I'm Pauline Foreman. I'm a GP in West Hertfordshire, and I'm the Medical Director of Primary Care Development. Would you like to introduce yourself, Ellie?
Hello, hi, my name's Ellie Fowler. I'm the Deputy Lead Practice Manager Advisor for the RCGP, and I work in primary care in and around Cumbria.
So Ellie and I, as you've heard, both work for Primary Care Development, which is part of the Royal College of GPs. You're going to hear a little bit more about the services that we offer at the end of our presentation, but basically our whole reason for existence is to support primary care, whether that's providing individual support, support for practices, or at scale organisations. So this webinar is one of a series designed to address topical issues in primary care that we think practices may need some support with. The webinars are open to all members of the primary care team, and we're particularly keen to welcome practice managers, who we feel are under a huge amount of pressure at the moment with the speed of organisational change. As Naren mentioned, if you have any ideas for further sessions that you'd like during the webinar, please do make some suggestions in the Q&A box if you can. So these are what we're hoping to cover today. We're going to try and put some of the current challenges to general practice access and capacity into context. We're going to discuss ways of looking at this to identify pressure points. We're going to think about how we might be able to develop our workforce to maximise access and capacity, and particularly to take advantage of the opportunities offered by the Network DES in terms of additional roles. And we're going to share some good practice with some colleagues. And we're going to welcome Doctors Ebenezer and Singh and their paramedic Dominic from Wellington Medical Practice, and we're also going to talk to Dr. Mike Heber, who's had a very interesting and innovative role in supporting the extended workforce. And then we'll have some time for Q&A. So I really don't need to, you're all aware of the current challenges I know that we're under, but really I have to say that I've been a GP for about 24 years, and there's probably been more change in the way that care is delivered in general practice in the last 6 months than throughout the rest of my career. So we're operating under a completely different model, and this is obviously having a huge impact in the way that people receive care and the way that they access general practice, and it's also having an impact on our capacity with a hugely enhanced digital access, in particular total triage, remote consultations increasing, face-to-face consultations less so, remote staff working, services being reconsidered, reconfigured, and all in the context of an ongoing pandemic, and we're probably starting to see the beginning of a second wave now. Having to provide enough access to patients, particularly face-to-face when we're working with social distancing, infection control, etc., is a real challenge. And our workload was pretty unsustainable before COVID, if you remember. We also know that this is going to be a very challenging winter ahead. QOF is very much coming back online. We're in the middle of a massive flu vaccination programme. We've also got the DES. The DES is coming back in terms of service delivery from October. Staff are, often feeling tired and overwhelmed, so it's not going to be easy for us to provide good patient access this winter. So one of the things I wanted to say is that patient access is quite a political hot topic at the moment. Some of you will be aware of some of the controversy that there's been in the last week or so when NHS England took us to task completely inappropriately for not providing enough face-to-face appointments. So it's in that context that we wanted to discuss the issue really, so that we can start to think about how we can possibly maximise our access for patients. So let's start from the basics really. What do we mean by patient access? Well, really we mean patients or their carers being able to contact the practice with a query or concern and access a timely and suitable clinical or non-clinical contact. And what does good access look like? Well, it's really about delivering the right care in the right place at the right time from the right person. It sounds pretty simple when you say it like that, but the reality is that access is way more complex than this, as we all know. There's no one-size-fits-all solution here. Every practice or primary care network is actually unique in terms of their population needs and preferences, and also in their ability to respond. You know, there are some things that are just matters of fact. There are some areas of the country, for example, where it's extremely difficult to recruit GPs and other staff, and that limits, you know, that all these things have knock-on effects on our capacity. Also, access is just not about seeing patients quickly. It's also about continuity and coordination of care, and it's very important that those elements of care which are associated with better health outcomes are not lost. The other thing about general practice changing so rapidly is that the range of services and the type of workforce that we have is changing very rapidly. And I don't know what your experience is, but mine certainly is that it's quite difficult for reception staff, for example, to keep updated with who is doing what. Never mind within your own practice, but within hubs, etc. So it's getting more complex. And I think we always need to be aware of the fact that easy access to care is very important in terms of tackling health inequalities, really, because at the end of the day, it's the socio-economic determinants of health that create the most demand for healthcare. Okay, so what do patients think about the services that they're getting at the moment, and access in particular? I mean, we're doing remarkably well. The last patient survey that was published at the end of July showed that patient satisfaction with general practice remains incredibly high at 82%. I mean, a politician would bite your arm off to have that level of satisfaction, wouldn't they? However, that being said, they are less satisfied with some aspects of GP access. So, for example, only about 2/3 of patients find it easy to get through to their GP practice by phone, or are satisfied with the appointment times available, or describe their experience of making an appointment as good. So there is some room for improvement there. I have to say that this was obviously primarily done before COVID, so it may well be that there's a very different response now. So access, there's going to be quite a strong national focus on improving access that's coming down the tracks towards us. So that's one of the reasons why we thought it would be worth having a discussion about it at this stage. So it's a pretty key part of the new 5-year GP contract. Obviously, COVID has had an impact here, a good impact in some ways, because one of the drives is to improve digital access, and obviously we've already done that. And achieved a lot of that already through necessity. But there are other pledges that have been made, for example, to increase, at the moment there's roughly 1 million GP appointments every day, and there's a pledge to increase appointments by 50 million in surgeries per year, which is a big increase. It's not a drive to increase appointments with GPs, it's with anybody within the team. And NHS England and Improvement are actively reviewing GP access at the moment. And we know that there are 2 things coming down the track. We hope that there'll be better access data. And we know that there's going to be a new access improvement programme. So I'm going to talk a little bit more about appointment data sets, because at the end of the day, until you know what you're dealing with, you can't improve it. Good data is the key, really, to making any improvements. And there's been some developments on that in the last couple of weeks. In terms of patient experience, there is going to be a new and real-time measure of patient experience, but we really don't know very much about that at all at the moment in terms of what the details are likely to be. Now, in terms of the Access Improvement Programme, again, we don't really have, apologies for my dog, the perils of presenting from home. It's the postman again, I'm afraid. The new Access Improvement Programme, we know is going to be based on what works. There have been a number of incentives or initiatives before around access, and those of you who are quite long in the tooth like me will remember advanced access from 2000, when all patients had to be seen, for example, within 48 hours. It didn't work, and actually it reduced patient satisfaction. So nobody wants to go there again. And this improvement programme will take into account continuity of care and health inequalities. But again, there's been no, it hasn't been negotiated yet, you know, with the GPC, etc. So there aren't any other details of what it actually entails in the public domain. So let's go back to data and GP appointment data in particular. So NHS Digital, as I'm sure you're aware, has been publishing information on our appointments since 2018, and that information is taken directly from the data on our appointment system. There's something called the GP workload tool that's within you know, EMIS System 1, etc. And you can see that data yourself on the appointment screens. So there are a lot of issues with the data quality that they provide, part of which is related to the quality of coding and the type of information that we actually enter at the end of the day. And obviously there's been a huge change in the way that we deliver appointments, and it's pretty clear that we're not always necessarily recording all our activity or interactions with patients on our appointment screens, and that's been reflected and perhaps has possibly led to some of the misunderstandings around our activity and workload recently. So NHS England and the BMA have given guidance. They've actually defined what an appointment is now, and this is how they want us to document appointments going forward. So a GP appointment is a discrete interaction between a health or care professional and a patient or their representative. And from now on, they want all appointments to be recorded in our appointment books, ledgers, whatever we use. And that includes all the health and care staff, not just general practitioners, nurses, etc. And it includes the new network DES roles. So we need to make sure that we're recording our clinical pharmacists, etc., social prescribers, particularly the social prescribers, because there'll be additional payments in the in PCN funding for doing that. And we have to make sure that we record all forms of interaction, so not just face-to-face, telephone, but videos, home visits, and online consultations in particular, and in all settings. So we need to make sure that we're recording our appointments in extended access hubs, for example, as well as in our own practices. This is just to show you what the GP workload sort of looks a bit like in EMIS. I'm an EMIS girl, so I haven't got a System 1 slide to show you. It's a very useful information for your own, when you want to look at access yourself. It gives you a huge amount of information, again, depending on how well you input the data, but your activity, utilization of appointments, DNA rates, overall by session holder, so for every different type of health and care professional, and it also gives you some breakdowns by demographics, so it's very good for looking at activity and capacity. Okay, but appointment utilization on itself is not actually the whole picture when we're trying to improve access for patients, because it doesn't really take into account demand. Okay, it also doesn't really take into account demographics. Those two are very closely linked, as I'll show you in a second. Patient flow, continuity of care, and skills mix. So I'm just going to break that down a little bit more. So demand and demographics are absolutely interlinked, really. In terms of looking at your demand, it can be quite difficult. People sometimes look at their third available appointment, that sort of thing, which is also available on the GP workload tool. Sometimes you have to resort to old-fashioned demand audits to see actually, looking over a week, how many actually requests you get for appointments. That's becoming even more tricky now as we're getting requests for interactions online. You can do some quite fancy analysis of your phone data to look at your demand, and obviously you can look at things like patient feedback as well. But it's important to know it's not just enough to see what your appointments are and how they're being filled. You've got to actually get some idea of what the unmet need is out there. Demographics are our main driver for demand because obviously age, sex, socioeconomic deprivation are big drivers of demand as well. And it's important that you know what your demographics are, and there are some good sources of that data. So there's, many of you will know the fingertips databases. Some of you might not know about the Royal College of GPs Workload Observatory. That's where Martin Marshall gets a lot of his information from when he's doing his blogs and answering things in the media. And I've given a link to you there as well in case you might be interested in that. Patient flow, so it's very important to have the right triage and digital solutions in place and to be able to map the patient journey. It's very important to make sure that you're not creating demand, and a lot of people are starting to say things about online consultation requests, for example, that they're struggling to meet that demand now because it's really, really escalating. And it's important that we don't create inefficiencies in the system so people aren't going round and round and round. They need to see the right person straight away. And we do have to think about people who are, have a degree of digital or health literacy issues and find it harder to get access at this time. So I'm coming up now to talk about, to hand over to Ellie and to talk about skills mix, really, because it's also important to know who does what best. So you may need to do some auditing of the appropriateness of appointments. Whenever you do that with GPs, they'll always tell you that half of the people they see don't need to be seen by a GP. And that is also happens with other healthcare professionals. So you really want everybody to be working, to maximum efficiency, really. Also very important that you're able to signpost that within the practice team as to who sees what, and also to remember social prescribing. So why do we need to do all of this? Why is it important when we've got so many other things on our plate, COVID, etc.? Well, it's really important because it helps us to better understand our practice and potentially our primary care network activity and workload. And it helps us to identify pressure points in the system and potentially to mitigate them. And it helps us to plan workload and service development in a much more proactive way. We're very reactive in general practice. We're always reacting to things, and that's very good. We're able to do that. We're able to be flexible and respond. But it would also be better if we had better data and could respond in a more proactive way. So we're going to do some polls now. Am I going to hand over to you, Naren, to do that, or?
What will happen is there's a question now on your screen. If you could just take a second to answer them, we should see the results coming up in a few seconds. So the question is, does your practice or PCN struggle with access and capacity at the moment? Never, sometimes, or every day. So nobody said never. 61% said they struggle with access and capacity every day.
That's pretty high, isn't it? Yeah, that's a worry, especially when the winter's only just starting.
So the next question is about getting the balance right. So I'll go through those one at a time. The first question is around, are you actively monitoring your practice demand currently? Has about an even split on that, with 48% of the participants currently saying yes, they are monitoring their practice demand, and 52% saying that they are not. Are you recording all your appointments on your appointment screen? So it's either yes or no. And 62% said yes, they are recording all their appointments in the appointment screen, and 38% said no, they are not.
I'm quite interested in that because I'd be quite grateful if people would just, if you're not recording them all, could you just perhaps put in the Q&A screen which ones you're not recording, because I'd be interested to know if it's a particular type of appointment. I suspect it might be the online ones, but I'd be really interested to hear what your experience is there. We finished with the polls, so I'm going to hand over to Ellie.
Lovely. Would you be able to just share? Lovely, thank you. Okay, thank you very much, Pauline. So I'm going to talk a bit about workforce, which is obviously relevant to how a practice or primary care network would provide patient access and appointments. So we've been looking at workforce for quite a while, and back in 2016, the King's Fund carried out a project to understand pressures on GP practices, and at that point, they highlighted supply and workforce factors as a feature which was providing pressure at that time. So in England, we have fewer GPs per 100,000 population than any other EU country. And on current trends, in 10 years' time, the NHS will have a shortfall of 108,000 nurses. And I also read in the news this week that in England, there are currently 40,000 nurse vacancies. So there is a workforce issue. So as you're aware, in July 2019, primary care networks were developed, and in part these were to help look at workforce issues. So there are currently 1,250 primary care networks in England, and the average size is 48,000 patients, with a minimum of size being 14,600 and a maximum being approximately 263,000, so quite a range there. So the primary care networks, so the PCN DES aims to provide 26,000 new healthcare professionals into the NHS, which is quite an increase. You're allowed to do collective recruitment within your primary care network, as I'm sure you're aware, with 100% funding reimbursement for specific roles. And the average PCN will be able to employ 7 full-time equivalent staff. So these roles, as part of the additional roles reimbursement scheme, are listed here. And actually last week it was also a nurse associate and a training nurse associate were also included in these roles. What was also confirmed when we were the announcement this week is that actually the funding for the additional roles reimbursement scheme can only be used on these roles and can't be used on any other ones. So there was a query as to whether it could be used for, say, a PCN manager, but that's not possible at this point. So it's just these roles. So as we were talking earlier about understanding your pressure points and your needs, primary care networks can decide how and who they recruit depending on your needs. So it's not an expected number or fixed expected number of roles per primary care network. It's whatever works best for your area. But by identifying your pressure points, this could help determine which roles work best for you. So if you understand your demographics and your patient population, say, for example, if you have lots of care homes, would a paramedic going in to support your care homes be a good role for you? Or if you have lots of patients with chronic diseases, would a health and wellbeing coach be a really good recruitment for your primary care network who could help with lifestyle support for those patients? There's also an additional element of considering which roles you can recruit in your area, not necessarily just what the ones that you would like, and what can you afford? Something else to consider as well is the primary care network DES. Would the additional roles be able to support you with delivery of that? Would they be able to visit care homes, as we talked about, complete medication reviews, or support with MDT meetings? Also, how we're talking about reviewing what your demand is. If you're going to be reviewing the demand of, say, your GP appointments, and you find that your GPs are completing lots of medication reviews, could you consider how best to utilise these roles to release some capacity for your GPs? Something that we're going to be talking about a little bit later is about how are you going to provide clinical supervision to support and ensure patient safety, and how are you going to get your wider team to know which patients to book with who, and how as well are you going to get your patients on board and convince them that actually they don't need to see the GP this time and they can see someone else on the additional roles. And who's recruiting? Who holds the employment liability for the post? Is it the primary care network or is it the local community trust? So thinking about your pressure points and your demographics and the PCN DES support can help your primary care network to consider which additional roles are best for you.
Right, okay, so I'd like to introduce you at this point to the Wellington practice team who very kindly come to talk about their model of working within an extended team. So it's doctors Des Ebenezer, Nav Singh and Dom Baroni, their paramedic. I think I'm going to start with you, Des, if that's okay.
Yeah, thank you. Yeah.
So, Des, can you tell us a bit about Wellington Medical Practice and the model of extended team working that you've developed?
Yeah, sure. So I'm Dr. Des Ebenezer. I'm GP Managing Partner at Wellington Medical Practice. The structure at the practice is we have 14,500 patients. We're a single site practice. And since about 2016, we've been developing a consultant GP model practice. So the partnership structure is 5 GP partners and 3.8 full-time equivalent partners. And since the last 3 years, we've been expanding our allied health professional network and workforce. So we don't have any other salaried GPs at the practice. We do have Patsy Clifton, who's our advanced nurse practitioner and nurse manager, and she leads the clinical team, which is made up of advanced nurse practitioners, practice nurses, healthcare assistants. We also have 2 urgent care practitioners, one of whom you're going to meet later is Dominic. And we've also had a MSK lead, and we employed all these people directly before any of the network AR roles came in. So we've been developing that. We also have a wide reception admin team as well, led by Sally. And the reception admin team, we've moved a lot of the administrative functions that maybe the GPs were doing prior, like generating blood forms and reviewing clinic letters, towards the reception admin team, and we've streamlined the DocBan processes and the processes of the practice to enable that. We also have Tanya, who's our patient engagement lead as well. I think we'll be talking a little bit about her role as well. We're a training practice as well for physio students. We also have nursing students, foundation doctors, so foundation year 2 doctors. We're also a GP VTS training practice. And we've recently signed contracts to be a paramedic training practice, and PA students as well. And we have 1 physio who's part of the PCN. Myself and Dr. Singh are joint clinical directors, along with Dr. Mishra from Hollingswood, for Wrekin PCN, and that covers 82,000 patients as well. So I suppose the structure in the nutshell for our practice is a GP consultant model, but also valuing the expertise of allied health professionals, as well as the expertise of the reception admin team as well, because they are the first point of contact for most of the patients.
That sounds incredibly impressive, Des. I just want to know, could I ask you, what benefits have you seen, particularly in relation to access and capacity with this model? Are you there? Nav, are you?
I've just unmuted myself, sorry.
Okay,
So, hi, thanks Pauline, and thanks Des. I'm Navneet Singh, I'm a clinical lead GP partner here. I think we worked on this model over the last 4 years. Basically, in terms of benefits, it's diversifying the workforce, getting the right skill mix of highly skilled clinicians, so MSKs, pharmacists, UCPs, nurse practitioners, and increasing the capacity. And as you mentioned in your earlier slides, having an extended team who provide a great service to the patients, improving patient satisfaction, access, but at the same time, getting the senior clinical input for most of the patients when needed, improving the safety. So at the most basic level, that's the benefit. But if you talk about the GP partnership model, it makes it more sustainable and future-proof, and frees up our time to look at the complex patients, plus frees up our time to look after the wider picture, the PCN DES side of things as well. So it's a benefit to both patients as well as the GP partners.
So have there been any particular challenges around moving to this model?
So the challenges, I suppose we could put them in 2 boxes. The challenges internally for the team was an overnight restructure, really. So in 2016, myself and Dr. Singh took over as lead partners, and it was our very first partnership. And so that in itself was a challenge. And restructuring the role of the reception team, who were being asked to move from telephone answering now to actually doing some of the administrative functions and generating the blood forms. So that was an internal challenge, and they've stepped up really well and taken that role on fantastically. Regarding the allied health professionals, again, the challenge is moving responsibility towards them and increased capacity towards them, and supporting that with protocols and close supervision protocols. So I suppose that's the challenges internally in the practice. Challenges for patients. Patient demographic was quite traditional before, expecting a GP face-to-face appointment. In 2016, it looked like we just stepped in and completely tore everything up. And I think that was a challenge for patients to accept that. Firstly, they wouldn't be seeing a GP, they'd be seeing someone who isn't a GP, and they'd be seeing someone who's appropriate to meet their clinical need based on whatever they're presenting with on that day. Part of that involved Tanya, who's our patient engagement lead. So we employed a dedicated patient engagement lead to improve engagement with our patients with our new model of care. On our practice website, we invested on some patient information videos about the different roles. So actually interviewing our clinical staff members as to what they do. And I think even a couple of times I did some waiting room talks to the waiting rooms when we used to have patients in waiting rooms pre-COVID. And that was one of the biggest challenges, I think, changing the mindset of the practice population. But then it quickly became apparent that once they've seen someone such as the MSK physio for their back pain directly booked in by the receptionists, following a strict booking protocol, they'd then ask and be happy to see the MSK the second time round. And then it just became self-propagating. So that's patient challenges, practice challenges. And then I suppose there was some local challenges. Sort of, we're a very new model of practice, and we stood out like a sore thumb really in our model of care and our structure, and that itself drew some attention. And the way we manage that is we look for validation from sources such as CQC. So we've got CQC inspection and they validated our model of care. We also invited in the supporting change in GP team to come in and see us annually. So they annually sort of have a look, and I think we're coming into our 4th year of having them on site. And they've seen us and they've done a report for our model of care and they validated it. So we saw the challenge, but we met it, hopefully. And I hope that covers most of the areas, I hope.
I think that was a really comprehensive answer. That's very impressive again. So I think I'd like to move on and speak to Dominic now, if that's okay. Dominic, I hope you're not muted, but I was just going to ask you, you know, how long you've been working in the practice and what benefits you think you brought to the team. Dominic, just for everyone's benefit again, is a paramedic by training.
Hello, yes, thank you for having me on. So I've been within the practice now for just over 1.5 years. It came in and from a kind of quite a traditional route, worked on the ambulances for a little while, then moved and worked in urgent care clinics for out of hours, and then took up the post here in Wellington medical practice. So I think from a patient point of view, you know, I deal with all the home visits, whether it's triage over the phone or going out to see them. I deal with all the care homes, deal with the weekly ward round on the care homes, and deal with kind of the care home MDTs and all the end of life patients as well. Generally, I think it's that patient continuity that they get from seeing the same person again and again. Especially with end of life care and the care homes, you can build up a rapport with the patients and with the staff at those care homes. So I think from a patient point of view, they do get that continuity, which is really good and needed. And that's sort of like how GP surgeries used to run, many years ago now, where your own doctor would go out to see you. Well, now that's kind of me going out to see those people in their own homes. So I think they do like that. I think also benefits kind of patients because we have more capacity to be able to do those home visits and go out to those care homes as well. And I also see patients face to face in clinic as well. So there is also capacity in clinic to see patients.
That's brilliant. And I guess that's also very pertinent at the moment because we know that they've, NHS England have now agreed that in terms of the network DES that a non-GP can do, the care home specification and stuff. So it's great that you've already got that established. It's really, that sounds absolutely great. So have there been, I know from what you're saying, you come very much from the acute sector and then urgent care. Have you had any particular challenges moving into general practice, do you think?
So one of the biggest challenges for me was timings. Obviously you've got, I started off on 20-minute appointments, and I struggled with those timings for, for the first kind of few weeks, few months. But through kind of tutorials with the partners, they kind of gave you the techniques and skills to be able to, to get through those consultations. That was sort of one of the biggest ones for me was timings. I now do 15-minute appointments, and don't overrun that much. So I think over the year and a half, it's become a much slicker operation than it did when I first turned up in here running an hour behind each practice, each time I was in practice. But also blood tests. So blood tests were another one. I had never kind of seen blood tests before I came into, or interpreted blood tests before I came into general practice. I know that is changing now with the paramedic degree. Their third year is now very more focused on primary care, blood tests and minor illness, minor injuries. Whereas before when I did my degree, it wasn't so much that. So I came into primary care having never interpreted any blood tests. But again, the partnerships and kind of Dr. Ebenezer and Dr. Singh sat down and we had lots of tutorials around blood tests and around how to best interpret them. And they obviously know that I'll go to them anytime I'm unsure with blood tests. So they were kind of the two biggest things for me, because they're two big things that are dealt with in primary care, and also not so much difficulty, but I'd never seen kind of 2-week waits working in urgent care. You don't really see those. So I came into primary care very much focused on kind of acute conditions rather than looking at kind of chronic and the 2-week wait system. So that was obviously another hurdle that I had to get over, but that came with time and came with kind of teaching and leadership from the partnership.
I mean, it sounds as if you've had very good supervision and support, Dom, in moving across, because that's quite a big learning curve, isn't it? That you've dealt with there, obviously very successfully. Because we sometimes hear about some negative feedback from people who are doing extended roles in general practice about the fact that they don't feel that they get enough supervision and support. There was for example, a recent survey from the National Association of Link Workers that found about a third almost of link workers were thinking of leaving, and most of those were employed in general practice, and they specifically cited lack of supervision and support. But I just wonder whether we might just move on to talk to Mike for a little bit about that, because Mike, you've been doing a very innovative role, haven't you, in Kent, working as a clinical supervisor for colleagues with extended roles, but not actually in the practice, not actually working within the practice yourself. Do you want to tell us a bit more about how that works?
Yes, thank you, Pauline, and thank you for inviting me to talk.
Mm.
I'm a recently retired GP. I left my own practice a few months ago, and I've been employed to be a clinical supervisor as part of the GP Career Plus scheme, which is an NHS pilot, and I think it's got 11 operational sites throughout the country, but the main purpose of the scheme is to stop people like me leaving the profession and to make use of our skills to fulfill this need for clinical supervision. I'm also, my other role is Deputy Clinical Lead at Practice Development as well, which is why Pauline knows me and possibly why I've been asked to come today. But my role's been really interesting. I recently have been working with a practice that actually rings lots of bells with the stories that Des and Nav and Dom have been telling me. It's a practice of 19,000 patients. There's only 3 surviving partners. It's in a significantly deprived part of the south of England. And they have been very innovative as well in helping with workload. They've employed a paramedic practitioner, 2 clinical pharmacists, a mental health practitioner, which at the moment I think doesn't come under the PCN scheme, but may well do soon, and more recently a first contact physio. We've been well aware that these health professionals, as Pauline has already described, have in many practices been suffering from a lack of clinical supervision. We know from our practice development work that CQC has picked this up on many occasions and pointed it out as a patient safety issue as well. And it does lead to lack of job satisfaction. So I have been employed by this practice, actually funded by the GP Career Plus scheme, but it's fitted in very well with the PCN DES as well, to supervise a paramedic, a clinical pharmacist. I've also been supervising an ANP, although she doesn't actually come under this, under this scheme. Fascinatingly, the role of the paramedic that I've been supervising chimes completely with what Dominic is telling me. This practice has 2 huge nursing homes, 2 50-bedded nursing homes to look after, and they've also taken advantage of the nursing home DES to take advantage of the paramedic skills. So one of my roles when I was employed was to help the paramedic to develop his skills in looking after frail elderly. Very similar to what Dominic's been describing. He now does ward rounds or virtual ward rounds every week, and he's developed a very close relationship with the staff in both of those establishments. The interesting thing was that I'm sure, like Dominic, he had loads of paramedic skills that were relevant to being a paramedic. He was very good at the assessment of acute illness, and he was very good at the assessment of acute injury. But in the process of his development, we've been able to help him to become confident in the management of frail elderly, and very interesting, in particular, just in the same way as Dominic was describing, he's been looking at blood tests and interpreting blood tests too. The relevance of my role is that in large practices like this with few remaining GPs, they are really struggling for time to provide quality supervision. I'm impressed that DES and NAV have been able to do it in their practice, but in my experience, there have been very few practices that have actually had the clinical ability to provide quality supervision for the new employees who are doing this kind of work. So that's really what I've been doing, Pauline. And it's been developing the role as well as just providing supervision, if that makes sense.
It's great to hear about that, Mike, and it's really good to hear some really positive examples of how using an extended team works really well, and innovative ways of looking at support and supervision. That's absolutely great. It may well be that there are other ways of doing this, and if you're listening and you've got some other thoughts or ideas, and certainly if you've got any questions for the guys at all, then please put them in the Q&A box. Our guests have kindly agreed to stay on and answer some of those questions for us. So while we're sorting out the questions, I'm going to hand over to my colleague Vic Gaffney, and she's going to tell you a little bit more about primary care development and the services that we offer.
Yeah, thanks, Pauline. Good afternoon, everyone. I hope you're well. I just want to share a little bit with you about our practice and PCN support services. The college has got a long history of providing support to primary care, as Pauline has alluded to, whether it be individual practices or at-scale providers seeking to facilitate those new models of care to transform and improve and develop services and their workforce. This work, we started back in 2014 when the college was commissioned by Department of Health and NHS England to undertake the National Peer Support Programme, which was to support practices that were placed in special measures following their CQC inspection. That piece of work concluded in 2017, but between 14 and 17, the college supported 138 practices, and 113 of those exited special measures. Following that programme, it was identified that there was a clear need for support for practices beyond the stretch of the National Peer Programme. And this led to the introduction of the practice support team that was much later renamed Primary Care Development. So Primary Care Development are able to offer and provide comprehensive tailored support programme available to practices, and now of course it includes primary care networks that are seeking to make those quality and sustainable improvements. With general practice at the very heart of the evolving NHS, then the college is perfectly placed to help GP practices and PCNs navigate through this immense challenge and these massive changes. And the way in which primary care development work is delivered is that we have a team of around 80 advisors, a mix of GPs, practice managers, practice nurses, and a couple of pharmacists dotted across the country. And each of those people bring their own experience and their own expertise, so they're uniquely placed to deliver support. They're familiar with and have come across many of the challenges that primary care faces, and their knowledge and expertise can help you in your practice or your PCN to make the improvements that you're seeking. So you've met Paulie, our medical director, and Ellie and Mike, 2 of our 4 deputy leads, and all of those people provide the quality assurance across all aspects of our primary care development work. The consultancy support service that we provide are wide and varied. We supported and can support struggling or underperforming practices, those seeking to prepare for their CQC inspection, those wanting or looking to make sustainable change and quality improvement pieces of work. We can facilitate meetings, we can plan and develop away days. For example, giving you some ideas around organisational development areas such as building a team, improving collaboration, enhancing communication, culture change, shared decision making, and agree and embedding new ways of working. You heard Ellie talk about skill mix and workforce issues, and we can help with that. So we can help with a workforce analysis, helping to assess and optimise your workforce skill mix, assessing and helping to increase capacity, help with recruitment and embedding the new roles for PCNs, so that you and your PCN and the patient get the best possible outcome. It's interesting that the poll earlier was 61% struggle with patient access. So if you need any support, then get in touch, let us help. We can also help with strengthening your PCN leadership. We provide leadership development, and we're working with Lancashire University to develop a PCN leadership programme. So all of the consultancy services that we are able to provide, they're all bespoke and tailored to your needs. And it's blended to suit you. So it might be a mix of face-to-face, if it's safe to do so, or online, telephone calls, Skype, Zoom, whatever is needed. I think it'd be fair to say that we've had previously a reputation for being expensive, and we've recently restructured the pricing model, and as a result we've reviewed our costs, and I think they've been reduced significantly. We have the ability to respond, we have the ability to build and develop a service that you need. So if you're from a practice, if you manage a practice, if you're from a PCN or a CCG and you're looking to support a practice, if you are a PCN and you're looking for support or to make those improvements, if you're looking to build resilience to see you through the winter and the winter pressures, and this winter looks like it's going to bring more pressure than normal, if you're looking to undertake QI pieces of work, or even to stay off the CQC radar, or if you've got any other specific inquiries, then just get in touch. I think on my final note, I'd like to say that over the coming months, we are going to facilitate a series of peer-to-peer focus groups. We want to understand more about your needs and your challenges. And so we're looking for people that want to take part. So if you're interested in getting involved in one of our focus groups, then please get in touch. Thank you.
Okay, thank you very much, Vic. I'm going to hand back to Naren. Have we got any time left for questions, Naren?
We've got about 5 minutes, so I'm just going to ask just a couple of questions out of the ones that have come in. And the first one is for Dr. Ebenezer and Dr. Singh, just asking around how the model that you implemented, how did that change your working day for yourselves as GPs?
So yeah, I think both me and Dr. Singh will answer this if that's all right, Nav. Yeah. So I'll give a couple of examples of what our working day looks like, and sure Nav will as well. Regarding sort of home visits, the home visits are all sort of automated now, so we no longer need to do the home visits, and that's freed up a massive amount of time. We're able to sit in the clinical hub, the on-call hub, which we're in together today, and Dr. Singh will explain a little bit about how that works. And it's really changed our working day, and our time's used more constructively. So it's still the same hours as we used to do prior, but we're being a lot more effective because we're available to more allied health professionals who there in themselves are seeing more patients. So it's actually increased our capacity without increasing our workload. There's a bit of a paradox there, but it worked.
Yeah, so coming back to the clinical supervision, I think we identified the role and the need for clinical supervision in terms of governance and patient safety. So we've developed this room into a clinical hub whereby 3 of us, the two GP partners and Patsy, sit in most days, and all the allied healthcare professionals, the GP trainees, the foundation year 2 trainees can access us for supervision and advice as they see patients. There's no long waiting queues as you would find in most GP surgeries. So we're not seeing most of the patients themselves. Most of the direct patient contact is happening through these additional roles and the trainees. And as Des mentioned, that frees up the time to look at the wider things that the GP surgery should be doing, as well as focus on the PCN side of things as well.
And obviously, since that frees up more of your time, and a lot of it is you're doing more clinical supervision of these new roles. One of the questions that's come through is because a lot of the patients are being seen by other roles with various conditions. How do you ensure that you keep your skills up in those areas, and how do you ensure that you're maintaining oversight of cases such as multimorbidity?
So again, I think because we are supervising on a day-to-day basis, most of the queries would be coming to us, and the trainees and the allied healthcare professionals keep us on our toes in terms of kind of keeping us up to date with regards to the clinical side of things. Plus, we are still a training practice. We both have a background in education. We are trainers by background, tutors by background, and we've got 2 more additional trainers over the last 6 months. So we've got a strong training background, and we do regularly kind of do tutorials to develop consultation skills and topic-based discussions on a regular basis. So I think we have tutorials on Tuesday mornings, Wednesday mornings, and Friday mornings. So that's about 3 tutorials a week that helps to keep going professionally.
If I could just come in with an example, thanks, Nav. I suppose answering Chaim Fried's question, how do you ensure that you keep up the skills in this area? If we use the example of someone with iron deficiency anemia, if you're a GP dealing with iron deficiency anemia, you do a lot of it on autopilot, and through experience and knowledge, you just do that on autopilot. Now, managing that same iron deficiency anemia patient via an AMP or via a UCP actually involves a lot more involved teaching and a lot more involved decision making, that you've now got to transfer your skill to that UCP and to that AMP. I'd probably argue that it makes us more skilled in that we need to be able to explain at a granular level rather than doing everything on autopilot. It's quite a common question that we get from other practices. How do we ensure we don't become de-skilled? It actually increases our skills because we need to be on the ball and not operational autopilot. How do you ensure oversight of multimorbidity? Again, we believe that, again, using the example of diabetes, so a patient with diabetes, if someone speaks to us about a medical problem, imagine a chest infection, say, but they also need their diabetes managing, we can actually send that across that specific consultation query and that appointment in a specific dedicated diabetes HbA1c telephone call where they'll get their dedicated time to discuss that, rather than us trying to brush over everything in a 10-minute consult. We operate on 15-minute consults anyway, but multimorbidity is better dealt with by the experts in that area, some of which, or majority of which, actually live in the allied health professional world rather than in GPs. Hopefully that answers some of the questions.
That's great. Thanks very much, Des. I'm just aware of the time, and I'm aware that a lot of people will need to get off for now. Thank you very much, everybody else, for your questions. We can try and get back to those of you who answered them separately. As I said, you will be sent a survey at the end of the session. If you have any specific questions, you can put them in there. Also, if you would like to have a chat with Vic, her contact details will be in there. If you just let us know, and she can contact you directly. So I want to thank everybody who participated in today's panel. It's been very interesting for me as a layperson, and I'm sure for those of you involved in primary care, it's been very interesting for you as well. So thank you very much.